Let's assume one clinical scenario. You are in emergency department and a 30-year-old female presented to emergency with history of consumption of multiple tablets. She does not give you history which tablets she consumed. She looks agitated. You took her vitals. She is tachypneic. Her respiratory rate is 30 per minute. Her BP is 100/60. On lower side, BP is on lower side. Pulse is 100 per minute. So tachycardia. You took temperature. She is febrile, like 38.86 degrees Celsius, let's say. So she is febrile, tachypneic, tachycardic. You did chest auscultation. There is no crepitations. So what are the differentials you are currently suspecting? So definitely this is some poisoning toxicity. So now you did pupil examination. Let's say her pupil is 4 mm and it is reactive to light. So pupil is not dilated nor constricted and it is reacting to light. So can it be salicylate toxicity? Can be. So you did ABG because she was tachypneic and her vitals were unstable, and your ABG report shows pH of 7.55, PO2 of 115 mmHg, PCO2 of 16 mmHg. So she is having respiratory alkalosis. You checked her glucose level, it is 130. So she does not have hypoglycemia and she is having respiratory alkalosis. So you might be thinking, oh, salicylate causes metabolic acidosis, right? So but her pH is showing respiratory pattern of respiratory alkalosis. So can it be salicylate toxicity? Can be. Yes, you are right. Salicylate causes lactic acidosis, ketoacidosis. So there is acidosis component as well, metabolic acidosis component as well. But predominant disturbance is respiratory alkalosis. Why? Because you know salicylic acid crosses blood-brain barrier and it stimulates respiratory center and it causes respiratory alkalosis. So there is both respiratory alkalosis and metabolic acidosis both. But predominant disturbance is respiratory alkalosis. So how do you manage now? I will administer dextrose D5 plus IV sodium bicarbonate. What? She is already having alkalosis and you are giving again bicarbonate. She is already having normal serum glucose and why you are giving D5? What is the rationale? Do you know what is the rationale? Let me explain. I told you that salicylic acid crosses cell membranes, blood-brain barrier, because it is unionized. But when it is ionized into salicylate and proton, it cannot cross cell membranes. So when we make blood alkaline, what happens that it gets into its ionized form. In alkaline environment, this weak acid dissociates into salicylate plus H+, right? So it cannot cross the cell membrane, it cannot cross the blood-brain barrier. And you know that salicylic acid is excreted via urine. So when salicylic acid molecule is in the renal tubules, this salicylic acid on ionized form, it can easily cross the cell membrane. So it can cross the tubular membrane and go again inside the blood and it raises the serum salicylate level. But if you alkalinize the blood and alkalinize the urine in the alkaline environment, this salicylic acid molecule dissociates into its ionized form and that ionized form cannot cross the cell membrane. So it is excreted in the urine. That's why we need to alkalinize, despite the blood is already alkaline, right? So despite the blood is already alkaline, we need to alkalinize more, right? And why we need to administer dextrose despite the serum glucose is normal? Yes, even if the glucose is normal, serum glucose is normal, there is neuroglycopenia. Brain neurons are not able to metabolize glucose, so you need to administer extra dextrose. So dextrose and sodium bicarbonate should be started from the beginning in case of salicylic acid poisoning or salicylic acid toxicity. And let's say the patient has prior diagnosis of end-stage renal disease, heart failure. In those conditions, if you administer bicarbonate, sodium bicarbonate, what happens that there can be volume overload, and that can aggravate the situation, like can cause pulmonary edema, can cause heart failure. So in those conditions, rather than giving sodium bicarbonate, directly go for dialysis, hemodialysis. Hemodialysis also removes this salicylate. And let's suppose you are managing this patient, she does not have any prior comorbidity, you are managing, and her condition is not improving in the first 2 hours. So her condition is now, it is like her mental status is going down. So in this condition, will you intubate right now or will you wait? Regarding this, I would like to tell you that don't intubate at this moment. Wait for some more time, because if you intubate, you need to administer some paralytics, some sedatives, right? So that will make condition more worse, right? So I can remember one case when I was in first year doing residency. I had intubated a case of diabetic ketoacidosis. Her pH was 6.9, and when she came to ICU, she was a young girl, and when she came to ICU, within half an hour, she was not responding. And I immediately intubated her, but I should not have done that. My seniors told me later that I should not have intubated, because in this metabolic acidosis, if this metabolic acidosis components resolves, patient regains consciousness slowly and patient feels better. So you can wait for some time being. But if there is dire emergency, like respiratory failure is occurring, ventilatory failure occurring, then obviously we have to intubate, right? But don't hurry for intubation in case of metabolic acidosis like diabetic ketoacidosis or salicylate toxicity.